This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Okay, thank you. So I don't need to repeat the title, it's up there. So just firstly, just a brief overview of the deteriorating patient. So vital sign abnormalities reflect the deteriorating patient, and they're used to predict potentially serious adverse outcomes, but of course they're not always measured and they're not always addressed. And the failure to act upon vital sign abnormalities can of course lead to adverse outcomes for patients. So things like increased length of hospital stay, increased mortality and morbidity, and increased unplanned returns to theatre. And then we can talk more specifically about ICU patients who have been admitted from the wards. So ward deteriorating patients who experience an unplanned ICU admission, they may not have received adequate care prior to ICU admission due to a failure to recognise and respond to vital sign abnormalities. So that is a failure to respond to the patient's deterioration. And there's research to suggest that ICU admissions from the ward have a higher mortality rate than those admitted to ICU from the emergency department or from theatre. So at the Canberra Hospital, we have the early recognition of the deteriorating patient program. And so this was established in 2007 to address these concerns surrounding responding and recognising patient deterioration. So the program consists of a colour-coded ward observation chart, a track and trigger system using modified early warning scores, as well as an educational package for healthcare staff called Compass. So I refer to these components as the multifaceted ward intervention from now on. And then we also have the critical care outreach service, which is triggered by ward staff when patients on the wards fulfil MET criteria or when the ward staff are concerned about the patient. So the team consists of the MET review team, as well as a dedicated critical care outreach service nurse and registrar. And so they decide the acute management of the patient who is deteriorating and whether or not that patient would benefit from an ICU admission. So what sort of evidence do we have for these programs? So there's been a small pre- and post-interventional trial done looking particularly at the multifaceted ward intervention, and it showed that there was in fact, after the establishment of the program, increased documentation of vital signs, increased likelihood of medical review, and fewer unplanned admissions to ICU, and overall improved hospital mortality. So building on that, our study aim was to determine the effectiveness of the multifaceted ward intervention alone or in conjunction with the critical care outreach service on hospital mortality in ICU patients admitted from the wards, as well as ward patients overall. So our study design was a retrospective before and after intervention approach, and there were 3 time periods that we were interested in looking at, and they're all 18 months in duration. So we had the pre-intervention time period, the post-multifaceted ward intervention, and then finally we have the post-multifaceted ward intervention and critical care outreach service. So these time periods range between 2005 and 2012. So the populations that we were interested in were, of course, ICU patients admitted from the ward, as well as all inpatient ward patients. And the outcome measure that we were interested in was hospital mortality. So this is just the raw data for our 2 groups that we're interested in. And I guess the main thing to take from this is that over time, patients coming to ICU from the wards increased at a rate that was greater than the hospital population. And I'll mention now too that within each of these populations and across the 3 time periods, the demographics of these populations were statistically comparable. So here we have some data. So this is data looking at medical emergency team reviews prior to ICU admission. So as you can probably see, there was an increase in the percentage of ward patients receiving a MET review prior to ICU admission in both of the post-intervention periods compared to the pre-intervention time period. And these data were significant overall, as you can see. And also, the addition of the critical care outreach service led to a significantly more MET reviews prior to ICU admission than in the multifaceted ward intervention group alone. And then next we have hospital mortality for ICU patients from the wards. So this is just, again, the raw percentages for hospital mortality. But a logistic regression model, which adjusted for patient sex, age, and Apache 2 score, showed that hospital mortality for ICU patients coming from the wards remained unchanged across the three time periods. But as I'll show on the next slide, the pattern was different when looking at overall ward patient mortality. So this is hospital mortality rate for all ward patients. So this is the adjusted hospital mortality, and again there was a logistic regression model used, and this adjusted for patient sex, age, length of hospital stay, and mortality risk. And the results overall were significant. And we did post hoc analyses, and they showed that pre-intervention hospital mortality was significantly higher than the hospital mortality in the two post-intervention groups. But unfortunately, there was no difference between the two later time periods. So the addition of the critical care outreach service didn't yield any significant findings or no significant result. So, as I mentioned, this study was a retrospective before and after intervention approach. So the very nature of the study means that there is, of course, no concurrent control group. And whenever that occurs, there's always a high likelihood of your study having confounding variables. So, of course, that's one of the major limitations that we have in this study. And as with all studies such as this, you have the problem of whether or not the findings are limited to the institution in which the study was carried out. So there's just a few major conclusions that we had from this study. So overall, we found that there was in fact significant increase in the number of patients admitted to ICU from the wards with the establishment of these interventions to recognise deteriorating patients on the wards. And there appears to be a change in the way that the patients are coming to ICU. So in particular, patients are more likely to have received a MET review prior to the ICU admission. And as I said earlier, there was no significant change in hospital mortality for ICU patients coming from the ward, but there is the suggestion of that patient mortality may have been decreased over time with the establishment of this clinical deterioration intervention. And that's all. Thank you.